Okay, I think I'll get started. We'll do a slow roll as people log in and start to arrive. And I just saw that we have one person joining us from Guam, and they're likely joining us from Wednesday while we're here on Tuesday. So we have a real variety of people here. So hello, everyone. Welcome to the first of the 6-week series, Fundamentals of Telemental Health. I'm David Jefferson. I'm the new Director of Training and Technical Assistance at the Northwest ATTC. I'll be your host for today, and we're very excited to have Dr. Sarah Smucker-Barnwell as our instructor for this series. Before we get started, I want everybody to know that here at the ATTCs, we believe that language matters and words have power. We strive to be culturally informed and inclusive and value your feedback and how we're doing. Please mail us suggestions at northwest@attcnetwork.org if you have any comments or questions. That email address will be available for you in several places, so feel free to use that. A couple of quick housekeeping things. First of all, if you have any questions for Sarah during the presentation, please type those into the chat box. Toward the end, we're going to allow for at least 30 minutes of question and answer time. And so I'll be moderating those questions and getting those to Sarah for your review. We'll also be getting an email at the end of today's webinar that has a link to a survey in it. Please take our survey. It helps us to make sure we're bringing you the content that you are interested in. We sent Dr. Smucker-Barnwell's slide deck ahead of time to you, and we'll make that available again tomorrow in a link along with a recording of this webinar. Additionally, we'll be sending everyone who attends this live webinar a certificate of attendance in about a week. You don't need to do anything to get the certificate unless you're watching in a group. If that's the case, please have somebody in your group email us within about 1 business day the name and the email addresses of everybody who wants a certificate. Again, please use the northwest@attc.org email address. As I mentioned earlier, today's speaker is Dr. Sarah Smucker-Barnwell, who is a licensed clinical psychologist who provides evidence-based psychotherapy and consultation in the greater Seattle and Eastside areas. Her research and publication interests focus on the ethical intersections of technology and evidence-based therapies. Dr. Smucker-Barnwell is a partner of Seattle Psychology, PLLC. She is the former director of telehealth training and education for the VA, Veterans Administration, Puget Sound Healthcare System. With all that, I'd like to welcome you to this evening's webinar titled Introduction to Telemental Health. And let's please give a virtual welcome to our presenter, Sarah Smucker-Barnwell. Sarah, it's all yours.
Thanks so much, David, and thank you to everyone at NWATTC for having me here today. I'm really excited to spend some time. We have these 6 weeks together, and today we're really going to start talking about the fundamentals of telemental health. Really getting into the very basics. I think we'll have some time over the next 6 weeks to dig into some of the specifics. But for the purpose of today, we're going to start off with those basics. So I'm Sarah Smucker-Barnwell. As David said, I'm a clinical psychologist in Washington, and I've really had this very fortunate career. I've had this opportunity to be involved in telehealth in a diversity of ways. So I think I began my career working in telemedicine research, working for large entities that were rolling out large-scale applications for how to really get evidence-based healthcare to large groups of people. I loved that work, and I loved thinking about how telemedicine could impact the public health. Through that work, I really got to missing clients. And so I came back to the Veterans Administration, where I actually first worked in their addictions treatment team. I was a CSATE fellow, a Center for Excellence in Substance Abuse and Training and Education fellow, and then I stayed on to be the director of telemental health and then later telehealth education and training. And I had this really great opportunity to work on a diversity of policy documents like the APA telepsychology guidelines and other similar documents that help guide our professions in the delivery of ethical telehealth. And I will jokingly say again and again, I'm an unapologetic telehealth evangelist. I really believe in this modality. I believe in its opportunity to expand care access, to bring your excellent clinical skills to clients who need them. And in this moment in time, to help safeguard the public health, protect your health, the health of your clients. So I really appreciate your having me here, and I'm excited to get started on this 6-week series. Today, we're going to review some of those telemental health fundamentals. We're going to talk about the implementation of telemental health. So we're going to talk a little bit about operational definitions. This can be a very jargon-heavy discipline. We're going to talk about themes related to selecting technologies for telehealth in your practice, determining what services you'll deliver via telehealth, thinking a lot about risk management, particularly in the era of COVID-19. So a little bit about the structure today. We're going to start off with some lecture, probably around 45 to 1 hour of just sharing information about telehealth. We're going to have some video demonstrations, so you don't just have to listen to my droning voice the whole time. Then we're going to review some questions that were previously submitted. Now, we're going to have live Q&A at the end, as David mentioned, but with 30 or 40 minutes for Q&A, we may not get to everyone's question. And if your question is not answered, please know that I will be looking through all the question logs, and or if you are like me and you think of your question after the webinar, please write down this email address, nwattctelehealth@gmail.com. This is an address that I'll be keeping an eye on, and I'll seek to answer folks' questions about telehealth as best I can. So I like to have these disclaimers. Whenever you do a technology presentation and try to suggest you know something about technology, it inevitably will fail and you will embarrass yourself. So now that I've said that aloud, perhaps that's a talisman. I'm really here to offer my best practice recommendations based on my clinical work, my review of the literature, and my experience in regulatory work. I'm trying to identify best practices and guidance in a developing area. But this is no proxy for reviewing our state regulations. If you have an attorney consulting with legal counsel, if you have a malpractice carrier, I always recommend contact them. Ask them what their policies are about telehealth. And I will, note that I'm not providing legal advice or clinical standards of care. And I like to always disclose any potential conflicts. I do in my life outside of this series provide telehealth training generally. So one could say I have a horse in the race of telehealth, but again, I am a known telehealth evangelist. I really do believe in this work. And I hope you will a bit too after today. Okay, so let's talk a little bit about definitions and examples related to telemental health. Telemental health, and you'll sometimes see it abbreviated as TMH because we love jargon and making ourselves feel clever. This is the provision of any mental health services using telecommunications technology. And this definition is, I think, diffuse to the point of almost meaninglessness. We're going to talk about such a diversity of technologies, but generally speaking, this is any remote mental health service that we are delivering to clients at a distance. And in the early days of telemental health, back about, 15 years ago when I started out delivering care remotely, and I should note I had a practice where I saw clients exclusively over telephone and video for about a decade. This was really about access. We saw clients in the most rural parts of Alaska, or I had a client who was a long-range trucker, and it was just fabulous work. It was work that we felt like we were getting care to folks who maybe would not get that care otherwise and perhaps had not had care previously, but really needed it. So I really I'll reemphasize this mission that access is at the heart of telehealth. And here today, in the context of the coronavirus and COVID-19, I think, again, access is really what we're talking about, access and public health and safety. So telecommunications technology is a really broad definition. I mean, this refers to most technologies we use in our day-to-day lives, in our practices: the telephone, our mobile devices, text or voice, emails, secure messaging programs, instant messengers, video conferencing, even a fax machine technically would fall under the rubric of telecommunications. So again, when I say that, when they trot out the idea like telemental health is just mental health care over telecommunications, this is actually a really broad definition. Now, I will say that most people, when they talk about telemental health, they are using this as being synonymous with video conferencing, sometimes telephone, but mostly video conferencing. And indeed, today we'll focus much of our energy in thinking about video conferencing and telephone. But it's notable that technically all of this could be considered telemental health. This can be a standalone service, or it can augment in-person care. So we may, at this time, many of us have transitioned our practices to exclusively video conferencing or telephone based. Others may be balancing, seeing in-person clients with doing some telehealth, and others may be having an entirely in-person practice. And please know, I don't seek to proselytize so aggressively that I would invalidate the choice to see folks in person. But I really just want to communicate that this is not a new clinical specialty. Telemental health represents the opportunity to bring your excellent clinical skills, the training you have, to clients through a different format. And really, I really feel this very strongly. And in fact, the notion that this is something that requires certification or requires, some sort of specialization, I really do push back against, not because it does not require training and thoughtfulness, but instead because I really want to communicate that this is just a different way of doing things. And indeed, I think we are living through a period of time after which video conferencing and telephone-based care will be more of a norm of services that are offered. I don't have a crystal ball, but I anticipate that even after things settle down, with regard to coronavirus and COVID-19, we will see that people still have a demand for telehealth, and we'll see more of this in our practices. Okay, video conferencing, this is our Skype calls, our Zoom calls, our FaceTime, really any two-way transmission of digitized video images between multiple locations. And, we're going to talk about today, there are really diverse products in video conferencing. There are products that are public facing and products that are non-public facing. That is, there are products that broadcast our video conferencing to the world so everyone can enjoy our witty banter. And there are products that keep things private between two people. An example would be Facebook Live, can show a chat, or Instagram TV can show a chat. Or alternatively, we can have Skype or Zoom, which is really intended to be between two people. Although, of course, today here, we are transmitting a Zoom call. So, within those non-public facing video conferencing products, those ones that are designed to just keep it between the participants, we have products designed for healthcare and products designed not necessarily for healthcare. And we'll get into this a little bit later. But I really just want to acknowledge video conferencing is a massive category with really diverse technologies, again, and really differing levels of privacy and security. And most of us have probably, done a Skype call with a friend, or, had to be on a Zoom call for work of late. So we probably have had some contact with that. But if we haven't, we're going to talk about ways in which we can, start off today. Briefly, I'll just mention online psychoeducation. Many of us these days, in the context of implementing telemental health in our practice, may be augmenting that with an educational website. So I know SAMHSA has some great material online. My favorite way to diagnose myself interactively with something terrible is WebMD. Mayo Clinic online. I happen to really like afterdeployment.org for a great SUD site. There are lots of different options, but I think we're seeing this come into more prominence, as we are no longer able to hand a book, hand a pile of documents, hand a survey. We're seeing folks choose more online formats to communicate information to our clients. And online psychoeducation offers one very viable option through which to do this. Mobile apps, again, really diverse set of technologies. I'm realizing that my image I've shown you has a Windows phone, so that tells you how outdated that particular images. Basically, any software that's on a smartphone, a tablet, all the various mobile devices. Technically, many of our watches have mobile applications. We may have clever wearable devices that we're using. What's notable is that the technologies for these are often specific to the device platform, whether it's Android or iPhone, BlackBerry. Oh goodness, maybe some things that are now extinct. All of these platforms have different underlying technologies. And the reason I mention this, and we're going to talk about this a little bit later, is it gets really tricky. It gets really tricky to think about which mobile applications are good for telemental health and which are not so good for telemental health, because we have to evaluate in each case, have they been designed with healthcare in mind? And because there are such diverse technologies underlying how each of these work, we really can't make a statement about the whole class. We can't say, oh, mobile applications are always good or always bad. It really is a case-by-case scenario. We'll talk a little bit later about how we might think about this and how we might select good products. Okay, HIPAA, our good old friend HIPAA. We have our HIPAA privacy rule, that we keep the information that we talk about with our clients private, and we have the HIPAA security rule, that we are safeguarding the security, privacy, and confidentiality from an information technology standpoint. And the thing I really want to mention is that, it is not prohibited to use video conferencing. It is not prohibited to use telephone. These are technologies that are regarded as potentially compliant with HIPAA. We'll talk about in a moment some of the changes that have occurred. Historically, HIPAA has required certain technological compliances for video conferencing and for telephone. These days, however, we are in an era where the federal government has come out and relaxed a lot of those requirements. So now we've had an announcement from the Office of Civil Rights and the U.S. Department of Health and Human Services that allows us to use a more diverse category of technologies, inclusive of video conferencing products, to serve our clients. So actually, for many of us, if we're getting started with telemental health right now, in terms of HIPAA, it's an advantageous time to start because there are fewer constraints, still important considerations that we'll talk about, but it's a less spooky place. Okay, PHI, this is something I'll talk about a fair bit today, protected health information. Sometimes you'll hear folks talk about ePHI, which is just electronic protected health information. And, most of us sort of came up probably as mental health practitioners knowing that things like your client's name or their address, or their birth date, these were things that we were to safeguard and keep private. With the introduction of technology into the delivery of healthcare, there are additional things like certain URLs or certain IP addresses or account numbers for software technology. So, really our general gestalt will be, we'll talk about treating our hardware and software as an extension of that PHI. The technologies we use fall under this category of information that we want to keep private, secure, and confidential. EMR, electronic medical record. This is just a digital version of the traditional paper-based medical record that we might keep for our clients. So Simple Practice is a great example, Therapy Appointment, TheraNotes, there are many great ones. The thing I'll mention is that many EMRs these days have integrated telehealth. We see a lot of them offer it either as a free or, for a small fee, you can add video conferencing capability to your standard EMR, which is really nice if you already use it. As I'll talk about a little bit later, if you don't use an EMR and you have a different system or a paper-based, record-keeping system, that's great. You certainly don't need to have an EMR to effectively introduce telehealth, and there are really nice standalone video conferencing programs that can augment your traditional paper-based record-keeping. But when I say EMR, this is what I'm talking about. Okay, BAA, a Business Associates Agreement. This is a contract between a HIPAA-covered entity and a HIPAA business associate. Basically, it says that they understand that I must comply with HIPAA, so they too will comply with HIPAA. And to me, the gold standard is anytime I use a technology product, I really want them, using that BAA. I want to know that they understand their obligations to me and that they will be a good actor, in the case of any problems. A good example would be if there's a security breach, will they report it to me? Or, many of the products that are great video conferencing products fail the mark of being HIPAA compliant because they have quality assurance practices in which they sample little chunks of calls and they look in, not because they're necessarily seeking to invade privacy, but because they want to check for pixelation, they want to check for lag, they want to see how it looks, and in doing so, they would obviously not be complying with HIPAA. So it's, if they sign a BAA, they can't do that. And actually, that's why many of the big video products don't do that, or they charge an additional fee. So that BAA is going to be our gold standard for knowing that a technology product is on the up and up as far as telemental health goes. Okay, I like this cartoon. Telecommunications can help. And then the dog says, I just hit delete. I haven't actually eaten any homework in years. This is the same clinical work we have always done. We're just trying to facilitate bringing it in a way that makes sense and in a way that improves access to care. Okay, sometimes you can talk a lot about what something is, but it can be helpful to say what it's not. You're about to meet my family, who are really, really good eggs about making example videos. So here is telemental health, what it's not. Well, we seem to be having some technical difficulties, as is the way these things go. We'll try one more time. And if not, we'll just move on.
Sarah, you have a volume button on the right. You want to check to make sure it's all the way up?
Yes, it does seem to be, and it worked just fine during our, but let's double check, because you never do know. Excuse me. Let's try again. Nope. Okay. Well, that's disappointing. Okay. Well, you can't give a synopsis on a joke, but basically, what I was hoping to communicate through this video was that so many times we, unfortunately, the internet is filled with folks who are, not adhering to the highest standards and the highest practices. And, I think that this is a marketplace that has really diverse showings. And, my hope and for this class and for generally telemental health is that we can understand what our best practices are and really seek to be the good guys out there, because there are a lot of folks out there looking to get prepaid 12 packages of therapy sessions, and they're a little more concerned with that than they are concerned with the outcomes for their clients. Okay. I want to talk a little bit about coronavirus and COVID-19 and the role that telemental health has to play. These are tools that are available to us during this public health crisis. I'm going to talk about in a later section of this series, many of us are now seeing changes in our local jurisdictions in return to work. Some of those restrictions are lifting, and many of us are making some choices. And some of us may have been essential workers throughout, wherein it has been something that we could choose to do or not to do throughout this period of time. But I think that telemental health is going to have a role to play for many of us as we figure out what is the best and most risk managed way to serve our clients in a way that safeguards our health, their health, and the public health. And again, I don't seek to suggest that we should or should not, as much as to say it's one tool that can help facilitate social distance. For some of us, we may work for entities or organizations that have now said that telehealth is the only option for us. And in these instances, it is, it's the only choice. And so that's, I think, again, we're going to be seeing transition over the next weeks and months, but I think, nevertheless, I think we're going to see more telemental health in our world in a post-COVID-19 world. And we're going to talk a little bit later, more specifically after we go through some of the fundamentals about what that might mean for us. Examples of how we can think about telemental health specifically in our practice. Okay, so when we conduct a telephone session, if we choose to email with a client, preferably using a secure encrypted email, if we had an interactive secure message, through, unfortunately through social media, which is not something I'd ever recommend, or, through a web chat, these would all technically fall under the rubric of telemental health. And look how happy these folks are using their telemental health. We can be that happy too. Again, most often when people talk about telemental health, they're talking about the provision of services using video conferencing. Increasingly, we're having to figure out how to bring this to testing and assessment, which we'll have an entire section dedicated to this theme, because that is a sticky widget. Adapting our assessment measures and our testing is tricky business. Using interactive mobile applications, using online psychoeducational sites. See, she received flowers. Isn't that nice and terrifying? Okay. So, I think I will say that although we so often refer to telemental health as being synonymous with video conferencing, I really think telephone is the unsung hero. Telephone was telehealth before we knew what telehealth was. Indeed, for many years, the standard of care for our clients in emergent circumstances between sessions was to use telephone hotlines. And this was regarded as a safe and effective way to, have some stopgap measure, between sessions. So it's a really important tool, and there's a pretty sound clinical literature for outcomes, for patient rapport, and for satisfaction. I will mention that, unfortunately, in many jurisdictions, the telephone session will be reimbursed at a lower rate for the video conferencing section. So I wanted to mention this early and often because I think it should enter into our calculus when selecting a technology for our practice. They are indeed billed differently using different billing codes. And again, later in the series, we'll get into all the nitty-gritty of how one does that. I will mention that in the context of COVID-19, many individual jurisdictions have passed regulation to support the parity of telephone with video conferencing. So they really have tried to pass some legislation because they recognize that video conferencing, may not be available to everyone. It requires, the money to have a computer and internet and all these things that could really create disparity in care. And so I think that we've seen some jurisdictions answer this by saying, okay, we are going to reimburse telephone at the same rate. But it's not every jurisdiction. And if you're looking for a resource, and I believe I mentioned this later in the slides, but if you're looking for a resource as to what your jurisdiction offers, I would encourage you to go to the ASPPB website, the Association for State and Provincial Boards of Psychology, and Psychology Boards, excuse me, I inverted those. ASPPB website has a really wonderful COVID-19 resource page in which they offer just a chart of, every jurisdiction in the US and Canada and what they have done thus far in terms of their regulation in response to coronavirus. So it's a long-winded way of saying telephone and video conferencing are both great clinical examples. I think there's really great data for both. Telephone, I think, is the unsung hero, but you risk, sorry, the folks are asking for me to say it is ASPPB. Sorry for that. But think about the reimbursement issue and think a little bit about what's gonna make sense for you in your jurisdiction. Okay, so this is my joke that congratulations, you're probably already a telemental health provider. It's good and bad news. But I think the idea of telehealth, frankly, is somewhat of an anachronism. I mean, really, this is just another technology we are using to bring your clinical skills to clients. Okay, so we're going to think a little bit about what technologies we can select for our practices. Okay, so when you're establishing your telemental health practice, you want to think a little bit about what services do you want to provide? What is your own comfort with technology, the comfort of the population you serve? I think that this, again, this conversation is really different than it was 6 months ago. 6 months ago, if someone came to me and they said, wow, I'm thinking about adding telemental health, I would say, great. Why don't you start off, pick a client who you know well, or pick a service that you're just really good at. So, for me, I don't know if I'm the best at it, but I think the thing I do most in my practice is going to be anxiety spectrum concerns that are comorbid with SUD. So that is going to be, the area that for me is just my bread and butter. It's work that I do all the time. And so that might be a client that I would be most comfortable with adapting to telemental health first. As a comparative, if I was just starting a new therapy, perhaps I got out of a training and I was just all filled with the verve of the newly converted, and excited to try it, that might not be the first case I brought to telemental health. So too, I might have been thoughtful about, which clients do I want to see, which clients don't want to do, what I not want to see, and we'll talk about that in a moment. But, now it's a really different conversation in the context of coronavirus. Now, quickly in my practice, I went from just having a handful, I always have some telehealth clients, but I have many in-person clients, to now all my clients are over telemental health. So in this context, I will say, think a little bit about what services you want to provide. Are you ready to take on, if you just took on somebody to do a prolonged exposure protocol, for PTSD, or if you're doing motivational interviewing, for SUD, are you ready to do this over telemental health? And I think it's some hard choices. Sometimes we may determine, no, this isn't something that I'm so familiar with, and I may want to think about referral, to a colleague. I want to say aloud that I have faith in y'all. We can talk about it and we can consult and we can get there. But I just want to respect and validate your own boundaries as a clinician to determine your own comfort with what technology you want to use and what services you want to provide. And at the end of the day, that is king. So, some things we'll need to have. We'll need to make sure that you have adequate internet, which again, 6 months ago is just as easy as calling up your local, carrier and saying, let's make sure I have really fast internet in my home. These days, it's a little stickier because everybody made that phone call. So, if you do not have adequate internet in your home connection, or if you are like me and you have a spouse working from home and a kiddo who is, homeschooling and there's a lot of demand, you may want to consider upgrading if that is possible with your carrier, or even getting a sort of additional resource for internet. So I'll tell you that, I went to my T-Mobile carrier, and for a, hefty $25 a month, I bought a hotspot. So now I have an additional Wi-Fi hotspot that has a separate source of internet. I also happen to have a mobile device that has the capability of serving as a hotspot as well. So for me, this was one way not only to have redundancy for my internet in case there was a problem, but to make sure there'd always be adequate internet. We need to make sure we have hardware and software that works well. So if we're doing video conferencing, we need to make sure that we have a camera and a computer that has adequate memory and processing speed to support the camera. If we are doing telephone sessions, we're going to make sure that we have, a phone, and that we are somewhere that has adequate service. And I really mention this in the context of mobile phones. So many of us have disconnected our home phones and may only have a mobile telephone that we use for our practice. If your house is like my house, there's some areas where the reception is great, and there's some areas where the reception is not so great. And so in those instances, we want to be sure that we are setting up our offices in ways that are conducive to supporting, the technology we're going to use to deliver care. Silly things, but it's the type of thing that somebody sits down to do and they realize, oh my gosh, I have one bar, sitting in this space and I just can't do it. Okay. So we really want to get specific, which platform are we going to use? And, how are we going to conduct, if we're doing telephone calls, how are we going to do it? For video conferencing platforms, we'll really dig into the different brands, but my general recommendation, I'll say this, they say you should say it 3 times in a presentation and folks will remember, is to choose a product that is designed for healthcare. I think this is the safest way. It's, something that will continue to be appropriate even after these executive orders relaxing the requirements for HIPAA expire. And I think it's just a good investment in having better technology for healthcare. So too, we'll decide how we want to have our telephone service, which again, you'd think, what are we talking about? Just pick up the telephone. But let's say you're working from a home office, well, do you share that telephone line with anyone else? Does someone else need the telephone? Is, someone else going to be receiving and making calls on the line? These are the types of things we want to be thoughtful about. And I generally will recommend that we want to make sure that we have the most dedicated service that we can, that is just for what we're doing in that office. So, it's the type of thing where I do recommend that people consider adding a line to their mobile device that is just for their business. I'll mention that many people elect to use voice over internet protocol, or VoIP, which is like Google Voice or Skype Voice or these things. Again, 6 months ago, I would have said, yeah, I don't love it. I think that they do some things that don't comply with HIPAA and high tech. That being said, in the current climate, these are all fine. And this is something that's a bit controversial. Some people will say it's just fine to use Google Voice and Skype Voice. My own feeling is for 10 extra bucks a month, I'll spend to have T-Mobile give me an extra line that's just for my business, and it's just an easier way to go. We want to prepare for PHI, so separate protected hardware and software. So again, these days, so many of us might be working from home, and maybe we use a computer that our kids also use for school, or our spouse also use to play, mahjong or whatever. We want to really keep these things separate. So having a separate profile on any hardware, on any computer that you use, having a login that doesn't auto-populate on that software. It's really easy, especially if you're using a Zoom account, to just go to zoom.us, and to accidentally log into another family member's Zoom account. So it's these types of things where we want to be really thoughtful about having unique profiles, unique passwords. Don't auto save them, so they auto populate to anyone who's hopping on the computer, but really treat this, like it's part of your office, where you see clients. And some of us will be doing this work from our professional office, which I think makes this a lot easier, to be honest, if you're doing telehealth from a professional office space versus from your home office. We'll dig into that a little bit. But we want to think about our physical space. Again, if we were sitting in our offices in our professional space, many of them are well situated. We don't have a ton of family pictures on the wall. We don't have, we don't have people running in and out of the rooms, asking where their homework is and things like this. And in our home, we want to be thoughtful about our physical space to an even higher degree, because all those rules of HIPAA still are, relevant to our home offices. And again, forgive me for giving this short shrift in the interest of time. These are the types of themes that we're going to really dig into later in the series and get into all the nitty-gritty. But today we're casting a wide net, if not, a deep one. Again, reimbursement is often going to be higher for that video conferencing than telephone. One of the interesting things I think is these asynchronous modalities. They're less well studied. So text therapy, email therapy, messaging therapy, I want to mention they're almost never reimbursed that I have seen by an insurance company. There's very limited outcome data on them. So I suppose in my best self, I would say it's an empirical question. I would probably convey a little bit of skepticism, because I think there's something about that, real-time communication that is so unique to video and telephone. But, hey, maybe the research will prove me wrong. Okay, so I wanted to throw out a case for us to think a little bit about. Mr. Kirk. Mr. Kirk is our long-standing client, and he is very technically capable. And he has some hearing loss. So that is something we've contended with in our sessions, orienting the space, typically sitting a little closer, speaking a little louder, ensuring that he can hear. He wants to continue therapy via Telemental Health to maintain his relapse prevention plan for alcohol use disorder that he has been working with you on. He has some reporting requirements for his PO because he had a DUI, which is what initiated his coming to treatment. He is sheltering at home and he has some health concerns, so this will probably go on for him even beyond when his jurisdiction says it's okay. He's probably going to be on the more conservative side and do as many things remotely as he can. He is someone who has some history of self-harm, and he had a hospitalization less than 5 years ago related to self-harm. So let's say Mr. Kirk is my client. I'm wanting to serve him via Telemental Health, and I'm thinking through these issues regarding, okay, well, how can I do this? What services do I want to provide? And is he the right fit for me? So what are some of the things I could think through Mr. Kirk? So first I might start thinking about, okay, what technology is going to be most appropriate for him? Now he's someone with hearing loss, so I'd want to make sure that whatever technology I choose, I want it to be steady and have, reliable audio. And we'll talk about this later on. I will mention, here's a hack, a fun hack, that if you're on a video conferencing call and the audio is poor, consider muting the mics on both sides and connecting the audio via telephone. It reduces the bandwidth demands on the video conferencing call, and I think provides a steadier source of audio while having a more highly reimbursed meeting. And I think you get all that good behavioral data we'll talk about in a little bit. Okay. So we want to make sure that hearing loss is addressed. We want to collaborate with that reporting office and the PO. Like, will they accept telehealth appointments? I know some folks in the SUD community have said, the POs are saying that a telehealth meeting isn't a quote unquote real meeting. A virtual AA meeting doesn't fulfill the requirement. I think it's a really unfortunate attitude. And it's my hope that that is not the majority of people's experiences, but it would definitely want to be something I would want to check on, especially, if there are things like he needs to do UAs or there's a breathalyzer requirement or something, I'd want to think through the practicality of what his specific legal requirements are. And, if Mr. Kirk is someone who has self-harm in his plan, in his history, I would want to have an emergency plan. Now, we always have an emergency plan in remote services. And this is something we'll dig into today, and we'll dig into even deeper later on. But we want to make sure that we have, not only for self-harm concerns, what would we do remotely if Mr. Kirk disclosed intent to harm himself, but what are we going to do if he experiences a relapse? I know many of our clients are struggling right now. So even though he has a good amount of sober time under his belt, I would want to be thoughtful and planful about how I would support him if indeed, this came to pass. Again, these aren't prohibitions against serving Mr. Kirk. They're just things I'd want to think through before I sat down for that first telemental health session with him. Okay, guys, I'm crossing my fingers. Here's another video for us, and I really do hope it works.
Hi, Sarah. If it doesn't work, I'm going to try something on my end and try to play it with my myself unmuted. So if you want to try that, then we'll try something else.
That sounds good. I like these videos so well. Okay. Okay, I'll give it a go.
Okay, here I am. I'm ready to figure out how I'm going to provide telemental health services. I'm ready to figure out, what technologies I'm going to use, what services I'm going to offer, where I can do this, how to prepare my office and get ready. Okay, they tell me I'm supposed to find a place where you can see me clearly, and that's pretty easy on the camera. All right, well, this is not it, right? First of all, you can only see the top half of my face. So I'm going to adjust my camera. That's a little better. That's just using my laptop, but I bet if I used a book to prop it up, it would be even better. And I'm looking behind me, that lamp that looks perfectly normal in my office looks like a terrible bright sun in the background. Now that I'm kind of looking around this room, well, there's a picture of a communist leader wearing a party hat. That might be a little more disclosure than I feel like making, in a session, but perhaps not on a webinar. And I didn't make my bed. There's a bed in here and they can see that. That wouldn't look very professional. Okay, I'm going to pause and I'm going to try to find a more professional orientation for the camera in the room. And come to think of it, wearing a t-shirt and wearing my yoga pants seemed like a really good idea a moment ago, but now I'm seeing on camera, it looks a little informal. So maybe I'm going to throw something else on and see if I can't help myself out in that way. Well, that's a bit better. My background is really austere, so nobody can really, see too many family pictures or art. They won't see my messy bed. This looks a little more professional. Put on a jacket over my yoga pants. Let's be clear, I'm still wearing those. And let's see, I like that this room, you can see that the door is closed. So clients will know that that part is secure. And let's see, maybe I can back up off my camera a little bit. Back up off my camera so they can see more of me. And again, I could change that angle just a little more, make me really more in the middle of the frame. That looks pretty good. Okay, I just checked my internet speed test and that was pretty good. So I think I'm in pretty decent shape to offer video conferencing services. That could be something I could offer. Maybe I'll do some practice this week with some friends and family using this tool so I can get accustomed to it before I bring a client in. But since, this would be newer to my practice, this is something I could try out. So I think I'm pretty ready to offer video conferencing. Now, let's think about phone. I have a phone. That's a good start. But what's my reception like? Well, I've only actually got one bar here, so that's not so good. If I wanted to do telephone services for a client, I could have a few options. If my Wi-Fi is decent, perhaps I could tether my phone to Wi-Fi to have mobile calling, or honestly, if I'm just doing a telephone call, if there's another private space in my house that has better reception, that could be an option. In this particular house, I happen to know that if I went to the kitchen, that would be the best reception. Now, in my house, there are lots of people in the kitchen. But, if I was during a time when I could have the kitchen all by myself and close the doors and have it be private, that could be an option. So perhaps in doing it that way, I could offer telephone services. Let's see. I happen to work mostly with adults, but also some kids and teenagers. And my practice is very much focused on anxiety spectrum concerns and trauma. So, if I was just getting started, this is just new in my practice, then, I might start with the clients that I just, they're my bread and butter. I'm quite used to doing the work. I might start off with those adult clients because I see mostly adult clients. And I might focus first on some anxiety protocols. How about a panic protocol, or, working with somebody on generalized anxiety concerns. Now, in the context of coronavirus, it may be that all my clients need to be seen via video conferencing, in which case, I may have to quickly be adapting my practice to serve as many as I can. But even if it really is the case that I'm structuring it within a week, my own thought would be I'd start first with those services that I'm most comfortable doing and have some, first goes with that. But my very first tests are going to be with family and friends, so I can really get the feel. Okay, I think I'm pretty ready to get going and see some clients both over video conferencing and telephone.
All right. Well, let's hope that our video calls lag less than I did just then. But, this is an example of how we want to be thoughtful about our physical space, especially if we're working from that home office. That's, I joke, the most boring section of wall in my house that I can find. There's no art, there's no pictures, trying to make sure that I'm modeling behavior that really tells my client, hey, this is a healthcare appointment, and helps benchmark expectations for them as well. Okay. So determining what services we're going to offer via telemental health. And I should note, if we have time at the end, I'll show you the first video. I thought it was snazzy. Maybe you will too. Okay, what services do you most often offer? Individual therapy, group therapy, consultation, and we want to think about how we're going to adapt those to the telemental health milieu. I want to think about and let me say one more word about that. When we're thinking about individual therapy and group therapy in particular, it's going to impact which technologies we select. For example, I think it is really challenging to do group therapy via telephone. I know people do it, and I respect that. I think they do a great job, but I think it's a little easier to do it with video conferencing. That being said, we want to choose a video conferencing product that is well suited, to handling multiple callers, multiple people participating. And later on in the series, we're going to dig into sort of what each product does well and where products might struggle. But, we want to think a little bit about what our technology needs, how they're going to intersect with the types of services we offer. Most often, people are thinking about these individual therapy sessions, and those are particularly well suited. As we have larger groups, we need to think about how to squish those folks in front of a phone or a camera, or how to facilitate their connection through technology. And I really just want to give a particular nod to folks who have assessment-based practice or forensic practices. And I think that they really have a unique set of challenges. Again, later in the series, we'll dig into more of this. But, I want to acknowledge that while many assessment-based practices are being thoughtful about how to adapt, I know Pearson, the testing company, is working hard to bring a lot of their assessments online and providing guidance regarding how to do observed testing remotely. I know the Trust did a pretty great webinar on how to observe the MMPI remotely, for example. But I want to acknowledge that there are some things you just can't do remotely. I don't know how, I do blocks with someone remotely and use the same norms, as part of the WACE test for intelligence. I think there are just a lot of things that are going to be really, really very challenging in the context of assessment. So generally speaking, my colleagues who have assessment-based practices, the guidance they're giving me is they are having more abbreviated batteries. They're using online adapted formats where they can. When possible, they're giving people the measures and observing, and they're acknowledging that there are going to be limitations to those norms. Where again, we want to think about what is the referring question. If this is just a question of diagnosis, which is not just, if this is a question of diagnosis, which is very important, I want to acknowledge that's really different than if it's in a forensic setting. So if I'm doing an assessment for a forensic setting and there's going to be cross-examination and I did not use the correct, norms for a test because of, just limitations on implementation, I do think forensics are having unique challenges that are just really difficult. Generally, I think folks are doing their best, they're adapting, and they are abbreviating, but I want to just recognize the real life limitations of what they're facing. Okay. We want to think through the population that we are going to serve. And I really, again, want to acknowledge pediatric providers have unique challenges. Now, for folks who are working with teens or younger children, it is very challenging. I think these kids are having a lot of what I would call Zoom fatigue. A lot of their schooling has been put online. I think it promotes a different set of boundaries, which we'll talk about more extensively. And it's just really difficult for kids. And so I think the population we serve may impact how we transition, to telemental health. Many of the colleagues I have who have pediatric clients or teen clients elect to have more abbreviated sessions. Sometimes more frequent, sometimes not, but they don't do, full clinical hour as much as they're doing 30 or 45-minute sessions. For clients, people who serve young children or families, a lot of times they're having parents help them to help kids attend to the meeting, if we have that type of parental buy-in and participation. And again, we want to think through the technological sophistication of the population we're serving. Are they comfortable with this technology? Is this something that's been in their life? And if not, how can we help them, get more comfortable without feeling, forced or judged in any way? As always, thinking through the necessity of additional monitoring. I'll tell you, there are products you can buy if you want to be really fancy, that have, of course, we can do remote UAs. There are home kits people can do. Tampering is a major issue with that. There are actual breathalyzer technology that plugs into USB ports for telemedicine. But then you're going to have to buy it. You're going to have to ship it to the client and hope you don't see it on eBay. It's a big investment. So I think most people are, not doing that. It's nothing I've ever done, but it's out there. Okay. So again, start with your preferred service modality. And some people are considering diversifying their practice when necessary. So for example, some of my colleagues who have, historically worked with adolescents, but had training with adults are now expanding to include more adults in their practice, just because so many of their younger clients, are struggling and wanting to meet less frequently. So I think some of us may be expanding our practices. Some of my colleagues who've had assessment-based practices are saying, hey, I'm transitioning to more therapy clients because it's just really tough to do these assessment cases right now. So I think it's a good idea for us to consider using telemental health as one way to, expand what we're doing clinically if we feel we have the training and are comfortable doing so. Okay, so who are we going to see over telemental health? I always like to mention there are few data-driven reasons to exclude clients. People say, oh, well, you're never supposed to see, someone who has suicidal ideation, or certainly we ought not see anyone who has, a more severe presentation. And indeed, there's just not that research. Now, I want to really acknowledge and respect people's boundaries may be that, that's just not the client they're comfortable seeing over this modality. And I think that's very valid. But, I'm not aware of research that says we cannot do it. And for me, I'm really always counterbalancing, the clients I feel most comfortable seeing with access barriers. I'm really thinking about, what are my clients, are they able to receive in-person care if not telemental health? And if not, does that change my calculus at all? Maybe it doesn't, but, I have to say in my own practice right now, it does. The client I might have thought, I'd rather see him in person 6 months ago, I'm going to be much more willing to serve via video conferencing now. I do always mention considering auditory and visual capabilities of your clients. I have a colleague who is herself blind and delivers services to the blind, and just talks about the ridiculousness of doing video conferencing for higher reimbursement rates. But I think it's a personal choice, and figuring out what each client needs and what meets their specific requirements. Okay, thinking through your selection criteria, how willing are you to navigate clinical emergencies at a distance? How willing are you to deal with reporting agencies, in the context of telehealth, and how comfortable are you managing if a client has relapse, doing this remotely? Acknowledging that, again, for many of us, there's not a ton of choice. Again, days past, we might have said, oh, well, gosh, I'm going to do this with my clients who are really have a lot of sober time, or, they really have very few symptom presentation. And now we may be in a circumstance where we're just having to make some hard choices. So thinking through availability of the appropriate technology for the client, do they have a computer? Do they have internet? Do they have an appropriate space in their home? I'm going to tell y'all, I have had some weird sessions over the last few months. I have seen people in closets. I have seen them in their bathtubs. I have seen them in their cars. And again, 6 months ago, I would have said, oh no, we don't do that. I would have really thought through whether or not telehealth was a good fit for them. If it was coming down to that. But in the current circumstances, they may have many children at home that are homeschooling. They may have a partner who is working, and I want to really be thoughtful about what gets them the privacy, confidentiality, and comfort, that helps them. What makes them comfortable, and what is going to help establish rapport in the modality and really help me be present in a way that delivers good care. I like the notion of a test call in advance of a new telehealth client, acknowledging that this is extra time. This is taking time out of your life. But particularly if they're not someone who has a ton of technological sophistication, or is just, they've never had any sort of healthcare at a distance, either having a test telephone call or video conferencing call to help, ease them into the modality, answer any questions. This isn't where I'm necessarily starting my intake, and I'm not necessarily getting into clinical issues at that time. But it is where I'm just making sure that they understand how the technology would work, benchmarking expectations for them being, in a private, secure space, benchmarking expectations that they really treat this like a healthcare appointment. It's a nice way to kind of get to know one another, particularly for new intakes. And we'll have a whole section of the learning series dedicated to new intakes. Okay, Jen, do you think you could unmute once more?
Yes, I'll start right now.
Okay, great.
Hi, Jason.
Oh, hey, Dr. Smucker.
How are you?
I'm doing great today.
Good. You getting some flossing in there?
Oh, yeah.
Jason, today we're going to take a few minutes to do our test call, to really have a little bit of a test drive with what it would be like to meet over video conferencing. I know this is something you've used in your life to talk with friends and families, but you've never before used it in a healthcare context. So part of the goal today is really to get a sense of what that would feel like, whether or not it's something for you, and to kind of go through the mechanics of it.
Yeah, that makes sense.
Okay. Well, first and foremost, if I may ask you, could I ask you to back away from the camera a little bit? Right now, I'm just seeing the lower portion of your face.
Yeah, no problem.
Excellent. Thank you. That's much better. What you wearing there?
Oh, this is my robe. It is plush.
Looks luxurious. Are you in bed right now?
Obvi.
Well, it does look super comfortable. I think moving forward, we're going to look to find a space that keeps you comfortable, but we also want to find a space that really feels like a healthcare appointment. When you come to my office, we really, we have a space that's, it's not as formal as, let's say, a classroom. I have a squishy couch and the comfy chair that I know you usually choose. There are lots of pillows. So we want to find a space that feels relaxed. But additionally, I'd like us to find a space that has you seated and upright, has the camera stable so it's not wobbling around, when the bed moves or shifts, and really just mimics something of that healthcare appointment feel. Does that make sense?
It does make sense. Okay. Next time I'll I'll pick something more appropriate.
Oh, okay, great. And then, as always, we want you a little bit back off the camera because, it's hard to see each other. We miss things. If I was tapping my toes or, twiddling my fingers, it can be harder to see. So when you're a little bit farther back in the camera, it just lets me see more of you and know what's going on and do my job a little bit better for you.
That makes sense.
Well, thank you for being here. We're meeting today over live video conferencing. This is a product that is designed for healthcare. So, some of the things that means. It means that that company, like myself, is adhering to the rules of HIPAA and other federal regulations that safeguard your privacy, security, and confidentiality. So this is really, a product that is made for healthcare and really has all the specific concerns, for our clients in mind when it's designed. One of the key features I like to mention to folks is that there are, security features such as passwords. Not anybody can just hop on our call. They have been responding to some of the things we see in the news, wherein that we've seen some people infiltrating video conferencing calls. So there's some additional securities there. And, this is never recorded. There's no transcript maintained of this, and you're never going to see a recording, of a product that is designed for healthcare.
Huh. Okay.
Well, what's on your mind? That sounds perplexing. I want to know.
Oh, I was grabbing some of this. Didn't know if I was going to put it on TikTok or Instagram, but I guess maybe that.
So this is something you're recording right now.
Oh yeah, yeah. I probably shouldn't do that.
Well, I'm curious, what are your reasons for recording? There are some instances clinically, wherein we do record sessions, but it's something we often will speak about in advance, not only to protect your privacy, your confidentiality, but to be thoughtful about my privacy as well. But, I'm curious of your reasons, and I'd like to know more about, what would cause you to record a session.
Well, I was thinking I'd put together a really cool TikTok remix, but I'll get something else instead.
I appreciate the free advertising, but no, unfortunately, that would not be one of those applications where we would record the session, but I appreciate it. Okay, so let's go over some of the basics. To join our meeting today, you received an email, and in that email, there was a link that you could click on that took you to this video conferencing modality that we're using right now. How did that go? Was that easy to use?
It was. It was very straightforward. The instructions were clear. It told me exactly what I needed to do, and it gave me great context for what was going to happen afterwards.
Great. And did you receive it 24 hours before your appointment?
I did. It gave me
Right.
plenty of time to review it, understand what I was reading, not feel rushed. Really helpful.
Good. A thing to know is that link will change session to session, so you should receive a new one 24 hours before your session. Some video conferencing products will have the same link every time. For security purposes, I like to change the link and the password each time, so you'll get a slightly different link will come in your email 24 hours before your appointment. I know that you had been in the waiting room. So there's that video conferencing waiting room, and that you entered into my room, once I came onto the call. And I wanted to know, what was that experience like waiting for the doctor sitting in the video conferencing waiting room?
Well, it was seamless. So, when the time started for our session, I was let right in, didn't really have to do or think too much about it. And it made it all just very easy for me.
Great. If ever it happens that it's 1 or 2 minutes beyond the hour, please know that I am coming. It does happen much as when you're in the waiting room in my office. There are times that I'm a few minutes behind. I generally have a policy that I should knock on wood. I will never be more than 5 minutes late. If at any time you became concerned, you can always call me. You have my direct line, so that is an option. But typically my goal always is to start right on the hour, because I know it can be really disconcerting for people to be sitting in an online waiting room, not sure if anyone's coming. We're all human, and sometimes I might be a minute or so behind, but it should never be more than 3 or 4.
Good to know.
Speaking of telephone calls, if we were to have some technical problems, if there were problems with the internet bandwidth that day or some sort of technology failure, and the call were to drop, my first step will be to try to reconnect the video conferencing call. If that problem persists, however, my next step will be to contact you on your telephone. So generally speaking, I'll ask you to keep your phone nearby. I should say mobile device, or home phone, whatever whatever suits you. But whatever you've listed as your primary contact in the electronic medical record, that's the number I'm going to be calling. So should we have a problem, that's what I'm going to be doing. First, I'll be reconnecting the video call. Second, I'll be trying to call you on the telephone. You know, there are moments at which if we were really just having a funky bandwidth day, everybody's home, homeschooling children, watching Netflix, working, maybe not in that order. You know, if we really did have a challenge, I would connect our audio over the telephone and we would keep the video of the video conferencing call. It's a wacky solution, but it reduces the bandwidth burden on the call and could be kind of a workaround if we were having technical issues.
That makes sense.
Okay. A few things about the modality that I wanted to review with you. A funny thing about video conferencing is the location of the camera. So there may be some moments where I might really appear to be looking directly at you. There may be other moments where my gaze may seem cast downward slightly. And this is really the difference between where you are on my screen, you know, and where the camera is on my computer. If it's a concern at any point, please let me know. It's something that we'll check in on and, you know, see how it feels. And it's something I could tell you over the telephone, but until you see it over video conferencing, it's sort of hard to describe.
I think that it's going to help me prepare for the experience. So yeah, that makes sense.
Okay. Additionally, you know, when we're meeting, I'll try to do the same. Try to back up a little bit off my camera. You know, I think it just gives us more of a sense of, you know, what that normal human interaction is. You know, when you say something interesting, I'll lean in, you know, or maybe if I see you kind of going like this, I'll see it more. You know, these are these weird little tells in therapy, you know, that sometimes we respond to in person. They really can get lost of the video conferencing modality. It's never going to be perfect, but one way we can mitigate that is by trying to back up off our camera a little bit and, you know, show up in that way. But I want to acknowledge that, you know, this is a modality that it can be challenging, you know, to get all of the information. So I really do try to slow things down and ask tons of questions. I'm going to be honest, even if you came in person to my office, I would be asking you tons of questions. It's literally part of my job. You know, however, in this context, in the video conferencing context, I just want to acknowledge there are things I miss. You know, there are things I can't always tell. I don't always know. Of course, I don't know in person either, everything, certainly. But just small moments, you know, that I don't want to make an assumption that I'm just going to ask you. You know, for example, if someone was in my office and they were really looking down, I might wonder how they're feeling. Are they feeling stressed? You know, how are they feeling about being here? You know, alternatively, if it's happening in someone's home, it could be that, absolutely. It could also be they're checking a text that they really have to check. You know, I just don't know what I can't see. So I really have the policy of asking tons of questions. You know, how are you feeling? What's going on? At any point, if it feels intrusive or too much, I hope that's something we can communicate about. But I want to foundationally tell you where that's coming from. It's coming from my desire to know what's going on with you.
That's really helpful.
All right, Jason, well, you know, we're going to have our initial intake that's scheduled 2 weeks from now. And that was, you know, the first available, but we wanted to try this out first and see how it felt. So, you know, I thank you. I know you've already completed your informed consent document online, inclusive of the emergency plan document. But, you know, I'm going to send you some additional measures if we decide to move forward that will include some assessment measures and some other information about your background that will help me get ready for that first meeting.
That all makes sense.
Okay. Well, thanks for your time today, Jason. You know, any concerns or questions about this modality before we end our test call?
No, I don't think so.
Okay. Well, how are you feeling about it? You want some time to think about it? Or are you feeling like you'd like to move forward?
I think I'm comfortable moving forward. I think the explanation you provided, it has comforted me, and I'm ready to move forward.
All right. Well, thank you, Jason. I appreciate your time here today. You know, I'll plan on seeing you in 2 weeks. And if in the interim you have any questions or concerns, please don't hesitate to reach out through that secure messaging portal in the electronic medical record.
Got it. All right. Thank you.
Thanks, Jason. Oh, hey there. Hey, that's a really great last point. You know, when we're having these video conferencing sessions, you know, we really want to try to do it in a private, secure space. So that would include not having adorable children and adorable puppies in the room, but really keeping it private, confidential, and secure, just like you would in my office.
You know what? I'll do that.
All right. All right. Sounds like a plan. All right. Bye, Jason.
All right. Well, I wish you all, you know, as compliant and friendly test calls as my play acting family provides us today. It's not always the case that everybody's so overwhelmingly, glowingly positive, but he's a nice guy and he's married to me, so he has to be a good egg about it. I think this test call gives us an opportunity to help our clients really get, sort of inaugurated into the modality and gives them a method to, start this off in a way that makes sense for them. Sorry, I'm having some troubles. Thank you. Okay, so an additional case presentation. This is for Mr. Spock. Mr. Spock is a 27-year-old veteran. He was diagnosed with an alcohol use disorder, moderate in early remission. He has also a comorbid diagnosis of generalized anxiety disorder. He's someone who's had repeat DUIs and he's lost his license. He has no history of self-harm, no history of hospitalization. So, we're thinking about giving care to Mr. Spock. What are our considerations? So I'd want to be thoughtful about what is his pattern of use. Has he engaged treatment previously? I'd want to know the role of avoidance and anxiety. I'll tell you, and this is something we'll get into later in the learning series, probably the only time I am really have a strong line on who I don't like for the modality is when there is avoidance, when the issue is, for example, agoraphobia, or some component of anxiety that is really enabled through avoidance. Telemental health can be problematic intersectionally. That being said, in the current context, I'll go ahead and deliver care as best I can. But historically, I want to be thinking through, what is the role of avoidance in his anxiety disorder presentation, and how am I going to counterbalance that if I am indeed moving forward with telemental health? He may have some barriers to care due to loss of his license, and I'd want to know more about his health status and his needs in case of an emergency. I'd be thoughtful about where does he live? Does he live in an area that does have emergency services nearby? I know I've worked with clients who live in places where, if I call them an ambulance, it's going to be 2 hours before one gets there. And again, that's not a reason I'm going to deny services necessarily, but it's certainly something I'm thinking about. And, I know there are some providers who are thoughtful about this issue of DUIs, when they have clients who've had multiple DUIs, they say, gosh, there's a public health thing here that I worry about my client driving. I worry about their safety. I worry about the safety of others on the road. Is telemental health one way that I can help address that? I think that the larger concern for me would be COVID, and how to mitigate that. But it is something that I would be thoughtful about, in conceptualizing this case. Again, not to tell you exactly what decision you would make for your practice, but these are the things I might be thinking through and thinking about whether or not to deliver care to Mr. Spock. Okay, let's talk about the theme of risk management. Again, we'll have a whole 2 hours dedicated to risk management. It's a big topic, but let's talk about some of the basics. These are the things I want to run through. These are some of the best practices we can do that really just kind of help us stay as safe as we can to sort of cover our practice, and to help encourage the privacy, confidentiality, and safety of our clients. Always, I'm choosing products designed for healthcare, those products that will give the BAA and be good partners in protecting PHI and complying with HIPAA. So for my video conferencing product, I choose a HIPAA compliant product. I will note that for most mobile telephone carriers, they're fine to use. HIPAA does not have an issue. The only question is when we start talking about voice over internet protocol, acknowledging that these days, many home phones and many office phones technically use a voice over internet protocol. And in those cases, this is where I say it's very sticky. So 10 years ago, we would have said that this is a trickier issue. I think for these enterprise level VoIP solutions, I believe the home phone in my area through CenturyLink is technically a voice over internet protocol. No HIPAA contraindications that I'm aware of for those large scale solutions. It's really when we start to get to the individual carriers that some of the technology issues have been flagged. But again, in the current environment, I think we're okay to use any of these products because, again, Office of Civil Rights has relaxed some of those HIPAA requirements for technology products. Always, I want to have an informed consent that is signed before I begin care. I think the highest standard is that we have it documented, an actual physical printed signature. There are many ways we can do that. We can do that over fax. We can do it over secure email. We can do it through our electronic medical record, perhaps, or if we have a program like DocuSign. If there's just absolutely no way, snail mail, carrier pigeon, if there's absolutely no way we can get that physical document in hand, there is a school of thought that would say, okay, I'm going to verbally review everything, which actually I do always when I'm having a first telehealth session anyway, but I'm going to document in the chart that, this is the choice I made. And generally speaking, for all of these risk management practices, I want to document. I just want to make a note in my own documents that says, this is what I thought, this is how I mitigated risk, and these were the choices I made. It's a good risk management tool for your own practice. As part of my informed consent document, I always have an emergency plan that communicates what I'm going to do in case of emergency. Again, there's a deeper dive to be had on this, but broadly speaking, I'm going to send emergency services to my client's home. In the case of, in a circumstance where my client has someone else in the home who is a supportive person in their life, who's aware they are in therapy, I may seek to obtain a release of information to have someone be boots on the ground in an appropriate circumstance. So, if my client has fallen over and broken their toe and someone needs to open the door for the paramedics, that's going to be a circumstance where I might reach out to, the person I have the ROI for, or more reasonably drive them to the hospital for their toe. But some emergency plan that recognizes, what I'm going to do in case of emergency. And that's something that the client is apprised of beforehand, and they're not caught unaware, that I'd be sending paramedics to their home in case of need. Generally speaking, you want to stay within your licensure jurisdiction. Again, we could talk more about this, but if you are licensed in the state of Washington, for example, serve telehealth clients in Washington. Now, I'll make a sidebar note that if you go to that ASPPB website, COVID-19 resource, some states have relaxed guidelines regarding interstate practice. There's some special considerations if you did elect to do this, but the safest way, the general rule of thumb, is stay where you're licensed. And that applies for telemental health just as it does for in-person care. I'm not allowed to drive down to Oregon or California and start delivering care. And so too, I'm not supposed to reach in with telemental health and deliver care to their citizens. Set boundaries with your clients. My spouse was wearing his robe. That is a very G-rated version of some things people tell me, that have happened in their cases and things that have happened in my case. We were talking about the unfortunate circumstance where you're having a video call with someone and somebody walks through the background. A, they shouldn't be in the background. This is a boundary. This should be a private and confidential call. But B, they might be in various states of undress. And I have to say, when it's happened, no one is happy. So we want to set boundaries and benchmark expectations with our clients that these are private, confidential meetings. Check with your malpractice carrier. Make sure that they cover telemental health. Most do. But, they may have some great resources. I know I work a fair bit with the malpractice carrier, the Trust, and they have all kinds of great webinars. They have sample informed consent documents for telepsychology and telemental health. They have some really good stuff. So, I would check with your malpractice carrier if you have a policy. If you are thinking through your own jurisdiction, thinking through what are your liability considerations for staff and clients, I've talked to many practice owners here in Seattle who have elected to transition to telemental health for the time being, not only for their health and their clients' health, but also for the health of their staff, for the folks who greet folks at the front door, for thinking through what their specific jurisdictional rules are for their stay-home orders, and then even beyond just ethically, fulfilling their ethical obligation to the folks they work with. And again, this is such an individual and specific thing, depending on the area we live, the prevalence of coronavirus and the specific health profiles of everybody involved. But these are just some risk management considerations. Okay, select cases that are compatible with telehealth, services that we feel we can offer. Start with those services we're most comfortable delivering and document that informed consent, that emergency plan, your decision making, and consult. The thing I really like about this Northwest ATTC community is it really is a community. And it's my hope that folks are consulting with one another, and you have my email, contact me. If I can't answer the question, I can point you perhaps to someone who can. I think that we can really lean into our colleagues. We're really all in this together. We're going through this really unprecedented time together. Okay, let's talk about Mr. McCoy. He's a 32-year-old man with active opiate use. He receives OST through typically an in-person clinic. He has a history of self-harm, and unfortunately, overdose was a part of that self-harm behavior. He's a traveler. He's someone who, for his work, must travel outside of my state frequently. Okay. So he was someone I would be thoughtful about, am I comfortable managing emergencies? And he's someone that I would really work through, emergency planning with him. Particularly if he is traveling outside the jurisdiction, and I want to acknowledge that if he is someone who receives OST and has a history of opiate use, unfortunately, not every jurisdiction has the same policies with Narcan that we have here in Washington. That's something I'd want to be thoughtful about. I'd want to know, can he receive his OST remotely? I think this gets an additional, for those of you who are prescribers, I want to say aloud that this adds some additional complexity when we start crossing state boundaries. And in particular, all telemedicine for certain controlled substances, something called the Ryan Haight Online Pharmacy Act, which actually limits some of our ability to prescribe certain controlled substances over telemedicine. Again, we'll get a deeper dive later in the series, but it's just something, if this is in your practice, it's worth a Google, or you can reach out to me and I can direct you to where there is more information. And will you see him if he travels? Here in Washington state law allows me to see Washington residents, when they travel outside the state. Of course, I'd have to look into what the states are, what the laws are in the state that my client is traveling to, and you'll want to think about what the laws are in your jurisdiction. And again, maybe they've changed a little bit in the context of coronavirus. So these are some of the things I'd think through with Mr. McCoy. Okay. Some of the major changes we've seen, and I've mentioned many of these, but I'll just go through them quickly. We've seen a lot of regulatory changes. As I mentioned, Department of Health and Human Services and Office of Civil Rights has relaxed some of the requirements around HIPAA, allowing us to use a broader spectrum of technologies. So your Zooms, your Skypes, your FaceTimes, these are now permissible to deliver telemental health. I'll say I still use products designed for healthcare. Honestly, if I'm going to get a board complaint, it's going to come not from a federal level, it's going to come from my state. I feel a little more comfortable. However, I mostly see individuals. If I wanted to see multiple people at a time, I'm not going to lie, I think these commercial products that are not for healthcare, they do it better. And that's something I would have to think about, particularly if I saw large groups of people, I'm not going to lie, the product I use does not keep pace. It does not have the same features. It does not have the same capacity. So I want to think through these issues. Again, interjurisdictional permissions have been relaxed. Many states and jurisdictions have seen executive orders requiring the coverage of telemental health now, and even the parity being reimbursed the same as in-person meetings. So this is a positive change. At some point these executive orders expire. Will it stay this way? I don't know. I sure hope so. And again, 6 months ago, this would have been this sort of question of, well, do we want to do this? Do we not? This is a really different question right now. This is being implemented very broadly, and the adoption among providers and clients is just a pretty steep curve right now. I think new considerations in the context of coronavirus, prior to coronavirus, if I had a client tell me they didn't want to do telemental health, I know we wouldn't even be having this conversation. Of course, I would see them in person. Now this is something I need to think about, and so I think managing client ambivalence in the context of telemental health is a really new area. Managing provider boundaries, thinking about, well, wait a second, what am I comfortable doing and not doing is just even more salient, because again, 6 months ago, I would have just said, oh, well, I'll see them in person. But now there may not be another type of care. And so I'm having to revisit some of these things. And again, similarly, a case I might not have seen when someone told me they have to meet me in their closet for telemental health 6 months ago, I thought, I was like, yeah, no, I don't think that's quite right. Now I'm going to do it. A thing we'll talk about much later on is the ethics of in-person care. There's been a lot of going out from American Psychological Association and other organizations this week about the transition back to in-person care. It has some really unique considerations, and I think telemental health, a continued presence of telemental health is generally recommended. And what are our own personal timelines that align with the rules of our jurisdiction, and generally, what we think is right for us and for our clients. Okay, so here's a review for our TMH fundamentals. We're going to determine what technologies we're going to use and what services we're going to offer over them. in some technologies, in some cases, I might deliver over telephone, and some I might do over video. It doesn't need to be one or the other. I personally have done smoking cessation work for many years, and it's, something I'm very comfortable doing over the phone, but some cases I really do want to do over video, particularly if I'm doing exposure work or, something where I really want to just observe more of the physicality of the client. So, it may be a case-by-case choice. Establishing my space to make sure that it's appropriate for telemental health, private, secure, I can be seen and heard easily. Selecting clients that I think are, well aligned with my own boundaries and comfort, documenting that informed consent, documenting emergency planning, making sure the client has access to the appropriate technology and space, staying within my jurisdiction. Modeling good boundaries and setting good boundaries in my informed consent, perhaps in a test call, and really thinking through, how am I going to engage this client clinically? We have a whole class on this later on, but how am I going to ask more questions, slow the pace, acknowledge there are moments that I'm just going to miss that behavioral data. I had a colleague tell me that a client had been crying, and they just couldn't see. Consider when we want to refer and where we would refer in the context of telemental health. Changes are going to be constant, the only constant right now related to COVID-19. We're in this really different regulatory environment, and we always have to be checking our jurisdictional rules. And again, this is a really broad overview we've done today. We're going to have more detailed elaboration of themes throughout the series, and we're going to hope to hit some of those today in the live Q&A. But briefly, I wanted to go over some of the great questions. We had a webinar a couple of weeks ago, and there were some really good questions. And I'm just going to take a moment to answer those questions. I'm guessing they may be some of the same questions that folks have today. And each class, we're going to have this section called That's a Good Question. So if you do submit a question to the nwattc telehealth@gmail.com email, hopefully it could be answered in this section. Okay, so probably the question I get most often is, what video conferencing platform should I use? And I'll say, again, I'll reiterate, use a product designed for healthcare, offers a BAA. I'll tell you, I use a product that's integrated with my electronic medical record. It is Simple Practice. That happens to be the EMR that I use. If you don't use an EMR, I'll jokingly say it might not be the best time to transition, because boy, that transition's hard. Really, expect a few months of wonky billing, and it can be a lot to make that transition, and probably you have other things going on at the moment, but if you feel really like it's what you want to do, more power to you. So products like Simple Practice, Therapy Appointment, TheraNest, TheraNotes, Secure Telehealth, these are all products that are integrated into an electronic medical record. There are also some standalone video conferencing products. I've written down one here that I think is probably one of the best, VSEE, V-S-E-E, and this is just a video conferencing waiting room and treatment room, not integrated with any EMR. So if you have another EMR, or you have a different way of doing your notation and record keeping, you don't need to change it. You could just add a standalone video conferencing product like VSEE. And if you wanted one that was free, there's Doxy.me. I will mention their free version only, well, initially, actually, excuse me, I was going to say their free version only supports individual callers, but they just this week rolled out a beta version where they will, even in the free version, be allowing groups, families, couples, a multi-caller situation. If you want to think about those non-public facing products that we're now allowed to use, Zoom, FaceTime, Skype, the usual suspects. Okay. Think a little bit about their features for security. Can you see your own self view? Do they allow multi-callers? How easy is it to use? I really cannot overstate, having a hard to use product is the worst. Do they have good tech support? And how expensive is it? I think I'm paying $10 a month for mine, and then I have a backup that's free. It's not a big expense for me. But if you wanted to use the HIPAA compliant version of Zoom, which is a great product, it's a couple $100 a month. So, I think you have to make a decision as to what's right for you. I had a few questions last week about, can you do groups in telehealth? And the answer is yes. There's a really strong literature for this. I think that the complexity increases with the number of sites that you get involved. Complexity, not just from a technology standpoint, but consider managing the privacy and security, privacy and confidentiality of all the members, wherein everybody is, so when someone's spouse walks through the background of one participant, they've now technically walked into the call of maybe 5 or 6 participants. So it really does add a lot of additional considerations. Jurisdictional considerations increase because, again, it's just hard to make sure everybody's where they say they are. And I jokingly call it the ESPN effect. There is, particularly when we have groups that are located in multiple locations. So I've worked in some places where there's one cohort in one place, one cohort in another. We're connecting them over video. These days, in the context of coronavirus, mostly we're doing like Zoom call or large video conferencing formats. But there is something to be said about, the ESPN effect being when there's one large screen, people tend to stare at it. So if you are doing these groups, consider using what they call gallery view, where everybody shows up at once. Otherwise, people tend to get tunnel vision. Okay. Client ambivalence. So, many people talk about, I have a client and they just want to wait till it's all over. They don't want to deal with this. And I think that's a reasonable position for the client to have. But I want to think a little bit about, what is my assessment of what's going on with the client? What are their clinical symptoms? If they're seeing me for SUD, how much sober time do they have? Do they have safety considerations? What if I don't return to the office in the timeline that they would want me to return to the office? Where could I refer them? So again, these are really novel considerations. 6 months ago, we would just say, well, of course, just see them in person. And now I think it's a bit more complex. And I will say here in Washington, we're essential workers. I've had colleagues who've seen people in person throughout, and I'm really grateful for them because I know I can refer to them, in the case that they would give good care to my clients who need to be seen in person. If they're just ambivalent about the telehealth piece. But if those clients are just not wanting to be seen at all, I think there is an ethical question of how much do we push a little bit, if we really do think they need care, and how much do we just acknowledge their boundaries and, let it go. Document those concerns. I can't say that enough. Document your concerns and your communications. One interstitial step I've often recommended is consider less frequent meetings. Stop asking questions, focusing on clinical engagement, because maybe, there's a question of whether or not they think they could feel connected. And this is a great place to use those MI skills. Okay, we talked about this earlier, and I'll just say again, if you cannot get that written informed consent, it just cannot happen. Documenting that you reviewed verbal informed consent is the next best thing. That being said, if you have a board complaint, boy, oh boy, that written informed consent, that's a good thing to have. Okay, well, we have gotten through all of our previously submitted questions, and now it is time for our live Q&A. And I'm going to hand it back over to David to help corral and direct me towards some of the great questions that you've submitted during our time together.
Wonderful, Sarah. And some questions have rolled in, and you've covered them to some extent, but I'm thinking about asking them one more time and see if there's anything else that you wanted to add to those. And also, in case a few more of our participants would like to submit some questions, we still have plenty of time today.
Right.
So Tom said, what about clients' poor broadband service, especially in rural areas with many of clients have limited broadband? What are your thoughts about that?
Great question. And, it can really be a challenge. Back in my VA days, we had a great program wherein we had the funding to send our clients devices that had integrated data plans. So maybe if they had broadband service in their home, but the area did have the capacity to have improved service, we would actually send them devices with great service. I mean, that's a really borderline, case. That's not the standard of practice. Generally speaking, I would say, I'm going to try first to reduce the bandwidth as much as I can. I'm going to encourage us both to have austere backgrounds, so we're not having to burden the call with a lot of visual data. I'm going to do my best to consider swapping the audio, so it takes that burden off the call. And what I find is that if I'm doing the audio over phone and that remains consistent, the chop of the visual can be a little less disconcerting. That being said, if it's just a fool's errand, that's a client I just see over telephone, hoping that they have good telephone service in the area. And I have some clients who actually drive to other areas and we do their session in their car because their area just has neither good internet nor telephone. Right. And I know we had discussed me turning my video on, so I'm going to show you my talking head while I'm answering questions.
Okay, thank you. You covered some content related to voice over IP. They were wondering if it's HIPAA compliant. You said you think that most of the voice over IP programs are. Anything else to add to that?
It's. I wish I had a better answer for it. Because I don't, and I'm going to actually go do homework on this again because I received really different answers. I've sat on some panels where regulatory experts have said, no, we don't like it. They don't give BAAs, technically it's over the internet. I mean, it is so broadly used. I mean, most major telephone carriers are using some adaptation of this technology. And so it's like unavoidable to me. And HIPAA has a very antiquated, as I understand it, and this is what I'm going to double check, they have a fairly antiquated attitude towards this where they say telephone's okay, internet maybe, but these days these are synonyms.
Mm-hmm.
And so I think it's a little confusing. Honestly, it's not one of those things that keeps me up at night because I think your risk is low, through using the modality. And really, all of this is a risk benefit negotiation, but I will go do some homework on that because I think it's a worthy question.
Okay. Thank you, Sarah. You mentioned several applications, health records. The person wanted to know in particular, Gilbert wrote, which applications are medically appropriate for telehealth? Is there anything else there?
I'm sorry, could you?
Yeah, which applications are medically appropriate for telehealth?
Well, I guess I'd want to know a little more about how we're defining applications. If we're defining applications in the context of mobile applications, like, we find on our iPhones or on our tablets, I would say that, again, we'd stick to the rule of wanting that BAA and wanting a product designed for healthcare. So, there is a lot of document management services that offer mobile apps. I know my EMR actually has a mobile app that's really spiffy.
Okay.
Alternatively, if we're talking about applications in terms of treatment modalities, I'm not really aware of that many that there's contraindication. I think, we're always thinking a little bit about the practicality. For example, I know this isn't in my practice, but I have some colleagues who do EFT tapping, and they're just saying, doing tapping remotely, how do you do that? And so fair enough, they're adapting, they're doing the good work, they're making it happen. But I think it's a harder thing for them to model, remotely. So I'm not aware of a literature that says, never do this therapy, over telemental health. But I do think you just run into some practical and logistical concerns that just, that guide us.
Okay. Well, here's a test of your IT skills. If the client is using cell phone for video session, will voice still be effective to reduce bandwidth?
Yes, I did this recently. I couldn't have answered it last week, but okay, let me say, maybe. It depends if the platform allows it.
Okay.
Sometimes some platforms have the problem wherein if they're using the mobile app for video and a call comes in, it automatically cuts their video. But what I discovered about my platform this past week is I was having this issue. Someone was using their mobile device to facilitate our video call. And unfortunately, we had to mute our mics and we put the audio over the phone. And lo and behold, in fact, they were in their car, and so it picked up on the car's Bluetooth, which was really weird. But indeed, their video was able to be supported. So I think it depends on the app, but we have the technology. It is possible.
All right. Okay. Here's another one. Lots of practitioners are new to video conferencing, seem to be complaining of screen fatigue.
Yes.
Is this the stress of adapting to a new medium, elevated vicarious stress from their clients, something about the medium itself, or all of the above?
I think yes. Yes. I think there's some, there's some just physical demands of it. I have some colleagues who wear glasses, special glasses to mitigate the blue light and the eye strain. I think they look a lot like Tony Stark and Iron Man when they do that. I don't myself have the snazzy glasses. I'm just going to allow my eyes to desiccate in their pits. But, there's a physical strain of it. I think there is something to be said. There's something almost performative about video conferencing. When I took my initial telemental health training, back in the day, they told me I should show 110% of my emotion in my face. And I thought, what a bizarre thing to tell me. I happen to have a pretty expressive head. And so it worked out. But I will say, when I had telehealth postdoctoral fellows, the first thing I did their first day is I would tape them and show them the tape. And these lovely, warm, just interpersonally delightful people who I really felt so much emotion coming from sitting in a room. When I showed them on the video, they looked like they were stone cold killers. You know, they really looked like it was bad. So I think it was this element of, oh, you know, they're having to bring an additional element of energetic sort of presentation. And I think that's fatiguing over time. And let's be honest, doing new things is hard and it's tiring. And this clinical work, I think this time in our clinical work is really tiring. I'm having a lot of the same conversations again and again in a way that's very unusual. My practice used to be just filled with such diversity of concerns, and it still is to a great extent. However, I'm talking to most of my clients about their concerns about their lives in the context of COVID-19. And of course, I'm dealing with this in my own life. You know, I don't know about y'all, but I find it fatiguing. So I think, you know, this participant brings up a lot of great points about why this is exhausting and Zoom fatigue is real. You know, so for that reason, I am considering shorter sessions. I know I've changed. I used to have these really long clinical days. I've compressed my schedule and spread it out over more days. So I'm seeing fewer clients on more days myself. You know, it's a personal choice, but I think that helps me counteract some of this.
Interesting. Thank you. Brian had a question. What do you suggest for approaches to providing clinical supervision?
Oh, it's a great question. Actually, I wrote a chapter on this for the casebook in telepsychology. APA published a casebook on telepsychology, and there's actually a chapter on clinical supervision. I'd say what's a sticky widget is that for psychology anyway, the the Committee on Accreditation has they publish what are called implementation regulations that guide us in various areas of practice, inclusive of supervision. And historically, they have, I believe it's implementation regulation 28, has some rules about how much supervision can be in person and how much supervision can be remote. So first and foremost, and this varies by level, if you're a pre-doctoral intern or a postdoctoral fellow, it differs. So I would say that, you know, first and foremost, we got to know where the trainee is in their training and what's the rule. I keep kind of hoping that we're going to receive some additional guidance, you know, from our professional organizations that we lack. I'm sure I haven't seen it yet, but if I'm just ignorant to it, it's possible it's happened already. But if we haven't seen it yet, I'm sure it's coming, that they have to, for people to finish their clinical training, they're going to have to relax some of this. You know, we have cohorts of interns and postdocs who are doing exclusive telehealth practice, and this is the first time they've ever practiced. So I would think that this is going to change, but first we want to know the rules. You know, second, I think we want to be thoughtful about, you know, I think there are some actually uniquely compelling ways in which we can use these technologies to observe cases. You know, when I trained back in the day, there was bug in the ear, you know, where somebody would sit with a little, you know, device in your ear, and you had one-way glass that your supervisor was watching you through and so helpfully giving you instructions, which was in no way unnerving, you know, while you were sitting with the client. I think there's an analog to be had wherein we have non-video participants on calls. Of course, all of this done in the context of informed consent and making sure the client's aware of what's going on. But consider the fact that we have the capacity to instant message each other, you know, subsets of who's on the call. We have the capacity to observe a call remotely. I think there's some unique ways in which actually the telepsychology, telemental health modality lends itself to supervision in terms of case observation and comment, real-time feedback. But then, you know, broadly, I think when we're just talking about the supervision relationship and going over this, it's much the same as I would say about therapeutic relationships, you know, being thoughtful, asking tons of questions, slowing it down, and structuring, you know, helping benchmark expectations and helping our supervisees understand their role, you know, in making this a successful interaction.
Oh, that's great. Like some new options, but also we want to follow some of the good practices that we've always had with clinical supervision.
Right, exactly right.
Well, we had a couple of comments. One from Katrina just noted that GoToMeeting is HIPAA compliant and every session is encrypted by default, and she put that in the chat. And then Lana made a note that most computer laptops allow for lowering blue light in settings and/or options.
Great points.
Okay. And then finally, we have one more question here. What about having interns observe sessions online with consent?
Another great way we can incorporate this into training, thinking through the opportunity to see our mentors deliver care. Again, we're swapping who's on what side of the glass. And actually, you're making me remember my first time being in that room was being on the other side, while I watched my mentor interviewing a client. So another great way with consent and, making sure everybody's on board, that we can help people, gain access into how we do this, not just in the telemental health modality, but, how we work clinically and how we work with clients.
Cool. Well, Sarah, that's the bulk of the questions at this point. There's one more that just came in. Is there a telehealth peer consulting group in existence in Washington State?
I'm aware of several, but most of them are tethered to practice groups. So for example, I lead one within my little home practice group, and we have folks who are telehealth only consultants. But gosh, I think the best resource I would suggest for you would be the American Telemedicine Association Special Interest Group. And this is a group that has an online forum. They have a listserv. You can post questions. Now, it's not the same as a consult group in the context of case presentation, although they do have a monthly call. Some of the call can vary in terms of discussion of policy or clinical issues, but they do have a call as well. And so I would say American Telemedicine Association has a national call, and then I believe they would be a great place. They can connect you to your regional sort of chapter of ATA, American Telemedicine Association, and in doing so, they can help you get connected to folks in your community.
Okay. If I wanted to start a new group in Washington State, what would you recommend that I keep in mind?
I would recommend a few things. One, getting that groovy document that we sign for consult groups that says it's not supervision, please don't sue us. And then I would encourage having, a couple folks there who are really familiar with the guidelines documents. So the American Telemedicine Association has great guidelines documents on video conferencing based practice, as well as evidence-based telemental health. The American Psychological Association has great telepsychology guidelines. Washington State, if you're in Washington, actually has telepsychology guidelines. Depending on your discipline, different boards, may have published different guidelines. So I would check with your state jurisdiction, see if it's Washington. I know, we have stuff actually in the WAC that talks about telemedicine broadly. I would check with your professional organizations to see what they have published. And then I would know those national guidelines, because I think that what's nice, I think, in the consult group is when you have somebody who knows these nitty-gritty things, if you then invite a diversity of folks, maybe some have been doing this a long time, maybe some are getting started. I think there's both this opportunity to have information transfer, regarding the policy and regarding some of the specifics, but then there is also the opportunity to have those great consult group relationships and, people at different places in their practice.
Wonderful, Sarah. Thank you very much. That's it for the questions. I keep watching to see if any more are coming in.
Sure.
And
do we want to show that first video since we have an extra 5 minutes? Is that too disruptive?
No, if you can go back, yeah.
Do you remember what slide it was, Sarah?
It is somewhere. Hold on, I can tell you exactly. Forgive me, I've had it right with me, but
here, 27.
Let me tell you, it is slide, I believe, 22.
22.
It might be. Yeah, I think it's.
I'm gonna think it's this one.
You are so right.
your audience members are helping you. That
Oh,
said,
thanks, guys. Well, right. Better late than never. Here's what not to do.
Oh, hello. I didn't expect to get a person. Hi there.
Hello, new client. How are you today?
I'm well. I was hoping to get some information about telemedicine.
You've come to the right place. I'm really excited that you're ready to begin telemental health therapy with me today. I know that regardless of what's going on, regardless of whatever issues may have come up in your life, whatever your history may be with treatment in the past, or really, whatever your goals are for the future, I know I'm the right therapist for you. So are you ready to tell me about your mom now?
Whoa, I didn't think it would go this quickly. I'm not even sure where I am. Is this secure?
I mean, did you close the door? Yes, of course it's secure. We're on the internet where we know everything is always really safe and secure. You know, there's a lot of technical gizmos and doodads that keep us secure. You know, I think what's important is that it's video conferencing. And we know a video conferencing call could never be overheard or intercepted or really interrupted in any way. So it's nothing you have to worry about. And in fact, you know, I know that you clicked on this and it took you to this, you know, entirely off-brand video conferencing product, but just because you've never heard of it doesn't mean that it's not a totally legitimate way to get your healthcare.
Okay. Well, I don't even know exactly who you are, but I guess what kind of doctor are you?
I'm like the really good kind. I mean, I'm the kind that you find on the internet where you always know that healthcare quality is assured. That's where you get all the best information about your healthcare, and you needn't ever double check or really, you know, do any sort of fact checking on things. I think, you know, what's really important right now is that we think a little bit about your treatment and securing perhaps a prepaid package, you know, perhaps 12 sessions or so, you know, that really come together in a therapeutic dose of treatment. You know, that'd probably be what I'd say our next step is.
You mean like an Arthur Murray dance prepaid program? Is that the kind of?
But for your feelings, yeah. You know, I think what's most important here is that you feel well informed, you know, in these next steps, you know, like where to put the credit card, you know, how to process the payment, and these things we can facilitate online.
Well, speaking of informed, like shouldn't we have some kind of understanding of what this is and what you're going to do with my information? And
like an informed consent document. You know, I figured you're like pretty smart, you know, so like I'm not so worried about that. Like, yes, typically an informed consent document would review things like risks to your privacy and confidentiality, the benefits of the modality, what we would do in case of a technology disruption, you know, what we would do in case of an emergency, what we would do, you know, in terms of payment or missed appointments or cancellations. But like, honestly, I trust you. I can like just see you're good people. So I don't think we need to really, you know, futz with all of that.
So you mentioned, okay, so what would happen in an emergency?
You should probably get a doctor then. Yeah. No, you know, like, you know, some people would do it where you have an emergency plan, you know, where we'd send emergency services to your house and really secure, make sure everything's okay. And that, you know, I could ostensibly stay on the line with you, but it sounds like a lot of hard work to me. I tell you what, I think the most important thing right now is that you go get that credit card. And then, you know, you click on this link again and we'll sign you up for those 12 prepaid sessions. And then I think we're really going to be ready to start some healing. Okay.
Yeah, I'm going to go do that and I'll be right back.
Okay, I'll wait here.
Well, thank you for humoring me. But, you know, I give this example and we do this in jest, but I've had the opportunity to sit on some regulatory board complaints and concerns, and jokes aside, I mean, there are folks out there doing this. You know, there are places you can go to buy, you know, prepaid, outcomes guaranteed therapy sessions by folks who may or may not be licensed. You know, there's a lack of any sort of informed consent or, you know, risk management going on. And so, you know, what is the joke is that, you know, you don't have to run faster than the bear, you just have to run faster than the guy next to the bear. You know, so too, I think in this telehealth environment, there is, you know, there's just a practical reality that unfortunately the bar has been low, and we have this opportunity. We have this opportunity right now to really transform the practice and to bring this technology ethically into our practice and to kind of be the good guys in this way and to deliver good care ethically to the people who rely on us. So I know it's about our time, David, and I want to say thank you to everybody who has come today and for all the great questions. We're going to have 5 more classes in the series, Tuesdays, 5 to 7 p.m. And if you look on the Northwest ATTC website, you can see the sort of subtopics we're going to address each week. If we didn't get a chance to get to your question, which I sort of think we did, but you know, if you're like me and you think of the question later, please, you know, email it in to nwattctelehealth sarah.j.j@gmail.com. That's an email address I'll be keeping an eye on, and I will do my best to include questions that I think are generalizable to other folks, on that's a good question section of the next class. And David, I know you were going to spend a few minutes, we're about 5 minutes till, and I know you were going to spend a little bit of time walking folks through again, how they're going to get their CE.
Yes, and first off, and forgive me, I hit paste a couple times, it wasn't showing up, and now our evaluation is showing up many times in the chat box, and the words that go with that are, could you please fill out our evaluation? We really appreciate hearing from you. For evaluations, if you were here today as a single person, meaning one account, we're going to send the certificate to you. If you're here as a group, we need you to send us an email with the names and email addresses of the folks that were in your group, and then we will send them their certificates. I want to thank you all for attending. We really appreciate your time. One of the folks from Guam noted that it was 3 a.m. their time, and they were very thankful for the quality presentation. Our next webinar is May 19th, which is next Tuesday. The topic is called Preparing Your Office for Telemental Health. So I want to thank Sarah again for your wonderful presentation, and thanks to all of our participants, the folks that kind of hung with us here all the way to the last minute. We look forward to the next session with you next week. So with that, Jennifer, do you have anything else?
Nope, I think you covered it. Thank you, David.
Okay. Bye, folks, and thank you very much, Sarah.
Thanks so much. Thanks to everyone for coming.
Sarah.
Thanks to Northwest ATTC for hosting and giving us an opportunity to spend this time together.
We appreciate you.
Thank you.